This is the case scenario of Mrs. S, a 30-year-old saleswoman from Vellore. She presented with complaints of fever 2 weeks back, loose stools 2 weeks back, burning and tingling sensation in both foot since 3 weeks, weakness of both lower limbs and numbness in both feet since the last night, one night before presentation. So she was apparently well until 3 weeks back when she had fever, myalgia, fatigue, sore throat, runny nose. It all lasted for 2 days and then resolved. The loose stools also developed 3 weeks back, which lasted for 2 days, around 15 episodes per day. It was a small volume, watery, green colored, non-blood stain loose stool. She also had one episode of non-bilious, non-bloodstained, and non-projectile vomiting. So the prodrome lasted for 2 days, 3 weeks to the day of presentation. She also developed 3 weeks since she developed burning and tingling sensation of both foot, which progressed upward up to the ankle. And there was no difficulty in wearing footwear, walking, or absence of ground sensation at that time. On the 31st of August, when she was sitting for a prayer at her home, she noticed that her right foot was numb. After that, she went to sleep. And then the next day morning, she woke up to see that she could not feel the ground. And she had twisting of right ankle while walking. She could not clear the step and both side toes would stub on the step. On the way to CMC, she also did not realize that the right footwear slipped off. She had no history of abnormal face. She had no history of facial asymmetry, no difficulty in chewing or swallowing or nasal regurgitation, no history of sensory symptoms, no weakness of upper limb. There were no bowel or bladder disturbances, no giddiness or postural hypotension, no constitutional symptoms, no features of oral ulcers, photosensitivity rash, Zika symptoms, or any digital ulcers. Past history-wise, she's nil comorbid. She's married for the past 2 years, been on treatment for infertility for the past 1 year, no history of any alternative medication intake. History-wise, nil significant, and family history also was not significant. Summarizing the history, it all started 3 weeks before presentation, 2-day history of short febrile illness, followed by that she had positive sensory symptoms in the lower limb, which progressed up to the ankle. She had numbness of her foot and foot drop a day before presentation. On examination, she was conscious, cooperative, oriented to time, place, and person. Her vital signs, pulse rate of 82, blood pressure 110 by 70 mmHg, respiratory rate 16, temperature was recorded to be 100.4 Fahrenheit. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. CNS examination wise, higher mental function was normal. Cranial nerve examination was also normal. Sensory system examination wise, the right and left upper limb sensations, the arm, forearm, hands were intact. Lower limb, bilateral thigh and leg sensations were intact. In the foot, on the right side, she had loss of pain, touch, vibration, and proprioception. And on the left side, there is reduced perception of pain, touch, and vibration, and proprioception was lost. Motor system examination, the bulk was normal in all 4 limbs. Tone in bilateral, upper proximal, upper limb distal, lower limb proximal were normal. Distal, lower limb hypotonia bilaterally was present. Power, the neck flexors, extensors, shoulder flexors, extensors, abductors, adductors, bilaterally 5/5, elbow flexors, extensors, internal, external rotators bilaterally were 5/5. Wrist flexors, extensors, bilaterally 5/5. Hand grip was good. Hip flexors, extensors, abductors, adductors, knee flexors, extensors, bilaterally were 5/5. Ankle dorsiflexion on the right side was 0/5. Plantar flexion was 0/5. Inversion, eversion was also 0/5. Extensor hallucis longus on the right side was dorsiflexion was 0/5. Plantar flexion was also 0/5. On the left side, the ankle movements and the EHL, the extensor hallucis longus, were 4/5. Deep tendon reflexes, Biceps, triceps, brachioradialis, knee, bilaterally or 2+. The ankle jerks bilaterally were absent. Plantars were bilaterally flexors. She had a high stepping gait. On cerebellar signs, meningeal signs were absent. Skull and spine was normal. Other systemic examination were normal. So this is a syndrome of asymmetric distal weakness with sensory loss. So probable differentials.
Was there pain in the legs?
Yes, sir.
She has pain.
That burning and tingling pain she had.
Burning and tingling.
Yeah.
Anybody with stuff? There is a distal weakness with the sensory loss. What you can think? Where you want to localize it? Both motor and sensory, and only it's distal. It should be length dependent. What organ should have been involved then? Nerve fibers. It should be a peripheral neuropathy, most likely.
So the localization is the peripheral nerves, and the differentials we considered were inflammation, acute inflammatory demyelinating polyneuropathy, vasculitis, sarcoid, infections like hepatitis B, C, E, HIV, leprosy was also considered. Infiltrative amyloidosis and certain toxins like arsenic and mercury was also considered. Because the patient had a prodrome of febrile, a short prodrome of febrile illness, loose stools, and then progressed to weakness of the distal bilateral lower limb. We considered AIDP as our first differential. We also considered vasculitis because it had both sensory and motor involvement, but she did not have features of systemic vasculitis like digital ulcers or gangrene. But still, that was also considered. And sarcoid, which can mimic anything from a polyneuropathy or mononeuropathy or mononeuritis multiplex, was also considered. Infections like hepatitis, HIV, leprosy, though the patient did not have any features of opportunistic infection or any recent blood transfusions or high-risk behavior. Leprosy also, she did not have any skin manifestations or any thickened nerves. Still, we considered as the second differential after an infiltrative amyloidosis, toxin-induced, no alternative medication intake, but still that was also one of the differentials we considered. And we evaluated the initial investigations showed hemoglobin of 11.8, total count 8,600 with the neutrophils of 66 and lymphocytes of 22%, and platelets normal. Urea creat was normal. Urine routine showed a WBC of 16 per Hypar field and RBC 1 to 2. Proteins were negative. LFTs showed deranged AST and ALT. Coagulation parameters were normal. Since we considered AIDP as our first differential, we went ahead with CSF, which was bland, and EMG also. It showed sensory motor axonal neuropathy with conduction block. And we evaluated for the, we did the autoimmune workup also, which showed ANCA negative. ANA was 2+ speckle. dsDNA was 558, it was elevated. SSA, SSB 172, it was elevated. 43, and C3 complements were normal. ACE was normal. BBVS was negative. We went ahead with a triple biopsy of her right lower limb, involving the muscle, the right superficial peroneal nerve, and the skin, which showed vasculitic neuropathy. And so with the ANA positive and dsDNA high, we calculated her SLEDAI score, which came out to be 15. The positives were vasculitis, pyuria more than 5 per Hypar field, high dsDNA, and temperature more than 100.4. So the other organ involvement was worked up urine 24-hour protein 149, lungs, heart were normal, liver, since the enzymes were deranged, we went ahead with an autoimmune hepatitis panel, which showed ANA 2+ and rest negative. APLA workup was also done. Lupus anticoagulant was markedly positive. And IgM beta 2 glycoprotein was borderline elevated 40. She did not have any clinical features of thrombosis or any pregnancy-related morbidities. So he did not satisfy the SAPOS criteria. So this patient presented, she was a new onset, she was newly diagnosed with SLE. For the first time, she presented with just neurological, just the peripheral neuropathy with. So approximately, this is a study which showed 40% of approximately 40% of neuropsychiatric SLE manifestation develops even before the onset of SLE or at the time of diagnosis, and around 63% develop during the first year of diagnosis. And among the various neurological manifestations, cognitive dysfunction is the highest percentage they present with. The second is seizure disorder. And the third is acute confusional state, and then lupus headache. Polyneuropathy is around 21%. 21% of the people involved in the study presented with polyneuropathy. And I just wanted to highlight the various therapeutic options for the peripheral vasculitic neuropathy in SLE. Corticosteroids, 1 mg per kg daily, with a reduction of 5 to 10 mg every week until maintenance of 5 to 10 mg. Cyclophosphamide, additionally or subsequently to corticosteroids. Pulse therapy is recommended 0.6 to 0.75 gram per meter square every 2 to 4 weeks. And mycophenolate mofetil is another immunosuppressant, though relapses are more frequent. This is also one other immunosuppressant we consider. And rituximab has been recently used as a therapeutic agent for ANCA-associated vasculitis. If steroids or cyclophosphamide show no treatment effect, then IVIG may also be a suitable alternative. So in our patient, we treated her with hydroxychloroquine 300 mg once daily. We pulsed her with methylpred 1 gram 3 days. Before that, we vaccinated her. We dewormed and gave iron supplements, calcium, vitamin D supplements were also given. So prednisolone, methylpred pulse for 3 days, followed by the tab prednisolone 1 mg per kg for 4 weeks, and then taper 10 mg weekly till 20 mg OD, and then taper 5 mg bi-weekly till 7.5 mg once daily, and then maintain 5 mg or 7.5 mg for the next 6 months. We considered mycophenolate mofetil because cyclophosphamide has teratogenic effects. So mycophenolate mofetil 500 mg BD for 1 week, and then 1 gram BD, along with the supplements, and Cetran twice per week. So the learning points in this case was SLE with initial neurologic presentation and the management of SLE with vasculitic neuropathy.
But how commonly do we see as index presentation of maybe even complications of SLE? Is it so common?
No, it is not a common.
Okay, but why can't it be just still para-infectious? You said it's all preceded 3 weeks earlier with fever, with the diarrhea, everything.
Preceded with the foot drop surgery. Definitely.
I think EMG itself will give everything except for whether it's part of vasculitis or not. I think one thing which would still favor your SLE is basically maybe vasculitis, presence of vasculitis from your biopsy, which may not be, which we may not. So because it's showing a vasculitic on your biopsy, it more favors SLE rather than para-infectious, which is mostly inflammatory. Okay. Any questions from audience? Did the patient recover any power? How was she after your